and thank you all for joining us today. For those of you who may not have had, for those of you who I may not have had the pleasure of meeting, my name is Brenda Berkeleyan, and I'm the collaborative co-lead of the McMaster Collaborative for Health and Aging, alongside my colleague, Dr. Rebecca Ganan, who is currently on sabbatical. And we call sabbaticals a gift in our particular profession, because it just gives you some time to focus on work that you might not have been able to focus on, as well as some new opportunities that are leading edge. And Dr. Ganan certainly is known for her leading edge approaches in all kinds of different ways. So what a pleasure I have to co-lead the collaborative with her. So we're very excited to be hosting our first collaborative conversation of this academic year. I usually like to wish people a Happy New Year in our world in September, but I'd like to welcome all of you, including our presenters, and they're going to introduce themselves in a few moments. But just bear with us here as we open the conversation. Today we are gathering on Zoom, and I'd like to begin by acknowledging that the land on which McMaster is built and where I've signed on from my home are the traditional territories of the Mississauga and Haudenosaunee Nation, and within the lands protected by the Dish with One Spoon Wampum Agreement. We acknowledge the importance of the land, which we each call home, in part to reaffirm our commitment and responsibility to improve relationships between nations and to improve our understanding of local Indigenous peoples and their cultures. And certainly this past weekend was one of reflection and an opportunity to hear and listen to the voices of those with lived experience of in Indigenous cultures and others. And certainly listening to those voices, so important every day, but an opportunity. And I thought, I turned on the radio, I turned on other media, and I thought the stories that were being told were really important and certainly helped to broaden my perspective as well. So we're always learning and growing, and that certainly is our approach here at the collaborative. So I take this moment too to invite you to join me to remind ourselves of our commitment to equity and fairness in our work and beyond. And improving fairness includes acknowledging and addressing those structural barriers and inequities which continue to exist in part due to the colonial history of Canada. So before we get started, I have just a few housekeeping items. The webinar portion of this event is being recorded, and it will be shared with you and posted with other past conversations on our website. So please feel free to disable your video if you don't want to be recorded on camera. And we will, however, stop recording before our reflecting together time that begins at 1 p.m. And I'll talk a little bit more about that reflecting together time in a moment. So questions and conversation are always welcome and encouraged at the end of the formal presentation, but please feel free to use the Zoom chat function throughout our conversation. So for those of you who are new or newer to the collaborative, we have one quick slide here to encourage you to follow up and learn more about what we do. And you can connect with us through all kinds of different ways. We are a coalition of researchers, trainees, older adults, caregivers, and others working to improve the health and well-being of older Canadians by advancing patient-oriented research on aging. And we aim to achieve this by providing research and engagement consultations and support, promoting training and mentorship, and facilitating partnerships and knowledge translation for patient-oriented research on aging. And we use the term patient here, but we know it's about partnership at the end of the day. And I think our health system and others are learning a great deal about the words and choosing our words carefully. So again, you can connect with us through email, X, which is formerly known as Twitter, YouTube, or LinkedIn, and you can find past collaborative conversations on our YouTube channel and website. So I want to mention, just before I turn it over to our speakers, that the Partnership and Research Fellowship is now open to trainees across Ontario. Very exciting. PhD students and postdoc fellows who are registered in Ontario Accredited University and engaged in aging-focused research are eligible to apply, so tell all your friends. You do not need to have prior experience in patient-oriented research or training and mentorship, and isn't that what it's all about, is learning and growing. If you are interested in this opportunity or know someone who might be, we ask that you contact the collaborative before you get started on the application, and our friendly team will certainly be in touch to help any way we can. We've had some fantastic projects. Our older adult partners have been amazing, as always, in terms of working as part of the team and providing feedback and helping in any way we can, of course, to help advance strategic patient-oriented research in Canada. I'm going to come back to our presenters in a moment, but I just want to just talk about reflecting together, and that comes at the end of our hour with our presenters. And we hope that you'll be able to stay and continue the conversation. And we're really fortunate that Dr. Michael Wilson and Ron Beleno will be sharing their knowledge and experience that are in terms of their presentation today, but we sometimes like to go a little deeper, and we're able to do that in the follow-up conversation. So thanks to Michael Kirk, who is one of our older adult partners who will help support that conversation, and we'll work through there. So hopefully you can stay on for a little bit longer in that reflecting together. I promised I'd come back to the slide. I know for people who are new to the series, this is where we bring together researchers and people with lived experiences to share their journeys and lessons learned in patient-oriented research. And today our guest will be speaking on the perspectives of citizens and stakeholders regarding the use of remote monitoring technology for older adults who want to remain in their homes and ultimately maintain their current level of function and care. And I'm so pleased to introduce our guest speakers who will elaborate on these introductions as we move through the presentation today. So Dr. Michael Wilson is the Scientific Director of the McMaster Health Forum and Associate Professor in the Department of Health Evidence and Impact at McMaster University. Ron Beleno, a community partner, caregiver, and board member in the Ontario Strategy and Patient-Oriented Research Unit, which we refer to as OSU, which leads Ontario's strategy for patient-oriented research. And we use the term SPORE. So all kinds of acronyms in this space, right, Ron and Michael? And we're looking forward to hearing more about the work you do together in partnership. So I will stop sharing and hand it off to our speakers for today. So thanks very much.
Great, thank you, Brenda. I'll be brief. I think Brenda shared my roles at McMaster. What my work really focuses on is on increasingly timely and demand-driven evidence support for government decision makers and system organizational and professional leaders, as well as citizens. And sometimes that means doing really quick evidence syntheses within very short periods of time. And sometimes it means also pairing that with deliberative processes with citizens and with system leaders, where we can have discussions and hear about values and preferences from citizens about how to address challenges, and then also from system leaders about what they think can and should be done. So that's where this project comes from. It was funded, but what I'm going to be talking about was funded by AgeWell through a platform grant that I hold from them that's focused broadly on supporting rapid learning health systems. And we've tackled a number of topics, one of which is remote monitoring technologies. And we have another one that's in play right now that I'll speak to towards the end of my presentation about integrated health innovation systems that kind of pulls together threads of some of the things we found in the deliberative processes about remote monitoring technologies that we did. And with that, I've worked with Ron actually through the AgeWell process on a previous project with my colleague Rosalie Wang, and now also on a couple of ones from this current funded project. And I'm excited that he's able to join us here today. He's always very dynamic and has lots of great perspectives to share. So with that, I can hand it over to him to introduce himself.
Thanks there, Michael. I think, Michael, when we connected was probably like the second year AgeWell was around. So I'm guessing 2016, 2017. This is the first time I'm actually, I think, even in a presentation with you. Like, this is like 8 years later. So I'm excited to be here with Michael and everyone else. Greetings, everyone. I'm Ron Beleno. I was a caregiver to a father that lived with Alzheimer's and dementia. And he's since passed in 2018. I'll share some of my slides here in a second. But I also care for mom, who is about 20, 30 minutes away from me. And I say that 20, 30, 40 minutes, depending how fast I drive on the highway. There's a reason I say that, because it's technically remote. It's a remote distance. But when my dad was around and we were having let's say, an emergency, you're kind of panicking. You're driving, you're not thinking. And I could get there probably in 15 minutes if I really broke the rules, which that wasn't the goal, but it is one of those. Just something to consider when you are someone who is a caregiver. And you're trying to provide distance care. So I'll share a little bit about that in a second as well. I'm also part of AgeWell with Michael, as Michael has said, AgeWell, which is Canada's Technology and Aging Network. And with AgeWell, I co-chair the Older Adult and Caregiver Advisory Committee across Canada. I'll share later as well that we do have a conference coming up. So if you are in the Toronto area, this is the best time to try and make it to this conference, first time in Toronto. And it is a great event specifically for not just researchers and trainees, but also for older adults and caregivers. Like you get to touch things, you get to touch VR, you get to touch cameras, sensors, all that stuff. So, and hopefully Michael will be there as well, and I'll be there as well, so you can meet us in person. So I will start my presentation here, and gonna bring in a little technology. That's me. And I think I will just be spotlighted for a second here. So everyone should be able to see me fully here with my presentation. And so this is a citizen and stakeholder perspectives about using remote monitoring technology for older adults. For myself, I'll share my story a little bit of what I was using, okay, during this time. My contact details are there if you want to reach me. Back in the day, some of my caregiving back in the day, when my dad was diagnosed from 2007 to 2018. Okay? He passed away at home. He aged in place as best as we could. That was quite a challenge, being an only child, also being the parents' favorite, you know, out of all the kids. That was one of the challenges that I had to go through there. So let's see here. Got that going. Oh, sorry, I actually started from the very end. I'm going to rewind this because it was at the, there we go. Okay. So being a caregiver, so this is more of a story that I'm going to tell you here, and then we can discuss later for those that can stay after one, more of this in detail. I was a caregiver, okay? We have different names. We have carers, care partner. Some will just say sister, brother, son, child, whatever that is, okay? So there's different words. Today, I'm going to use the word caregiver, okay? Just like patient partner, citizen, it really depends. Words do matter to some people. And for me, it is caregiver. And apologize if you hear some drilling. That is the condominium above me right now doing this. Okay. A little background, mom and dad. Oh, before I forget, this presentation, I'm going to squeeze this in about 10 minutes, which is usually a 30-minute presentation. So I will go fast. I will skip some slides, but you'll get the point of some of my messaging here. Mom and dad, being Filipino, they like to combine their names when they have a kid. My mom's name is Ronces. Dad's name is Reynaldo. Okay, they got the Ron on the Aldo. I'm Ronaldo. That's my name. Good thing my dad didn't go first. If he did, they would have got the Ray and the Ses. I would have been called racist. Okay, so I'm glad I'm not called racist. I'm glad my mom went first. Okay, there's a cat on the care team. That's Lucky. Okay, Lucky was part of our care team. Lucky will be seen in a video in a few minutes during some remote caregiving. Okay. A little bit of the challenges we were dealing with. Okay, so to understand remote care, you also kind of need to know, what are you solving for? Why are we going to bring remote care in our lives? Is it of value? Okay, you know, is setting up a camera system, okay, so that I could see my dad, you know, a great return, but the expense or the risk could be is that some privacy will be lost. Okay, my dad and my mom will have someone watching them. So we have to do all those calculations when it comes to caring for someone. So remote care, these were some of the challenges we were dealing with. Okay, you could see dad with dementia. Of course, there's memory loss. Okay, we were dealing with falls, so mobility challenges. Okay, so that's some of the stuff. My dad was known as a wanderer, someone who would leave the house and go missing. That was a big safety concern that we had. Okay, that was the first time I brought in some remote caregiving tools. Okay, without realizing I was remotely caregiving. Okay, so those are a few just to share. And this was the team that we had for one person with dementia here in Scarborough, where I live. I live by the Toronto Zoo, if anyone knows that. Know where the Toronto Zoo is. I don't live in it, but I live right by it. And my parents, again, are 20 minutes away. Those were some of the people that we needed to care for my dad, okay, during his 9-10 years of diagnosis, or 10 plus years, sorry, of his diagnosis, okay? So this you don't need to understand fully, but this is kind of related to me as a caregiver. Okay, a slide I've been using from the very beginning back 8 years ago. Always have worked on this here, where as a caregiver, these are some of the reasons why we are solving or creating solutions, whether it is high tech, low tech, the community helping out. Okay, this is what I've been solving for my work, which was I'm dealing with emotions. Okay, so fear of my dad going missing. Okay, the stress. Okay, that my mom has that she can't go to sleep because he might secretly walk out of the house in the middle of the night in the winter. Okay, known as a silent exit. Okay, those are some of the emotions. Creating the confidence. Okay, it's also building up confidence in caregivers. Okay, we're dealing with variables such as finances, the time. Okay, energy. How much sleep do I get? How much time am I traveling just to see my dad for, let's say, 15 minutes, and then I have to drive back home again? Okay, so those are a few of the things I want you guys to kind of understand as to why we bring remote care and other care tools and strategies into the mix. Okay. Very quickly, something I like to talk about is the calculating caregiver. I'm always looking at ways to bring in confidence to improve the chances of success for care. These are my slides. Again, I'm not an academic. I'm not a researcher by those means. And it's one where I say, what are the returns, okay, for bringing in some solutions? Is that really loud? Can you guys hear that, Michael? Oh, you can't hear that drill?
I can't hear the drill at all, Ron, so I think you're good. So
okay.
you probably have to deal with it, but the rest of us are good.
All good. Okay. So I will just work on that there like this. Okay. So return on investment. Okay. If I buy technology such as a sensor, okay, this is one of the sensors that AgeWell supports. Okay. From sorry, who is this game? Centenaire 2, Ultimview, right? Okay. This is a sensor that converts you into a stick figure. Okay. Deals with privacy. Okay. Something like that. Okay. How much does this $200 camera cost? Well, we had cameras back in the day for $50 to $100 that I still use 10 years later now with my mom, okay, which she's fine with. That was a high return, okay, on that. So I could check in on them, caring from a distance, caring while not being there, okay? So that is, I call it the return on the numbers, okay? There's all numbers here. And it just so happens return on numbers by accident spelled out the Rons. Okay, I didn't plan that, but if you ever try and figure that out, I'm always calculating as to what is the benefits and the disadvantages, let's say. Okay, technology as a tool, okay? I'd like people to think that specifically those that say, Ron, I've done talks and right away they say, I don't like technology, I don't want technology, don't push technology on me. And I remind people, I'm not here to push technology. I say, if you don't want it, don't use it. It's your choice. Okay. But I said, if you've gone to the bathroom this morning, if you've turned on the tap, if you've used the dishwasher, you've used technology, okay, to support your life, okay, in some way. Okay. I always remind people, plumbing is an old form of technology, okay, that still today we haven't succeeded in. Okay. There's many places that don't have plumbing, okay, here in Canada as well. But if you can get technology, you get these solutions. Okay, you can clean, in the house. You could keep the community safe with a fire hydrant or a sprinkler system. Okay, you could grow food in places you can't grow. So it adds to the quality of life for many of us by using the plumbing system. Consider the internet, okay, to support remote care. Okay, and here are some examples. And I know Michael will have a great slide that shows these examples as well. He talks about that. The internet. So these are just some examples of a camera, okay, to be able to monitor someone from a distance, okay. Computer, we've used it already. We're doing it right now to get information, to be educated, okay, to learn more, to get that one idea that can help when it comes to aging, when it helps to caregiving, let's say. We have these smart devices, which I'll show in a second here, like a Google Home or Google or an Amazon device, okay. I remotely play music for my dad back in the day before those devices came in, when he was a little stressed or when I knew that he needed a little more energy. I could control that from my house or anywhere around the world. Okay? So those are examples where technology can support some of these challenges that I'm working on or that we are all working on. Okay. And that is just a few that you can see right there. Let's keep going on. And I said, technology is simply a tool, okay, to connect us, okay? And if my dad at point B is 20 minutes away and I'm at point A, can I find a way to care for him remotely from a distance? Can I have, let's say, my aunt in California caregiving for dad from a distance, okay? So that's what we were doing back in the day, pre-pandemic. And that was just something I appreciated that I had at this time of where we're at in life of having tools and technology, okay? And as I'll finish off here, just some of Ron's remote care back in the day, okay? I will show one video here. And let's see if you guys give me a few seconds here. Share screen. Share sound. Okay, so this is a video, again, back around, I don't know, I think it was it's 2014 here, when this thing called Skype was still in. Okay, so Skype, that's used for a business tool back then to do a video chat. I was using it for caregiving, actually. And you will see me, with permission from my mom, with my dad who knew we had cameras back then. That's another conversation, the ethical conversation around privacy, the risk of having remote tools of monitoring someone. But this is one where my mom could go and do some activities while I would be right here at home monitoring him, caring for him, okay? Especially when he was at the risk of going out missing, when he shouldn't be walking out of the house, okay? So we were having that period where we were challenged with that. So here's the screen here. And you guys should see that. And you'll see him about to leave. I was able to care for him. I'm only going to play maybe 2 minutes here to relax him, and you'll even see Lucky the cat. Hi, Dad.
Hi, Ron.
How are you?
Where are you?
I'm over here.
How come you down here?
You just relax, okay?
Okay.
You stay home, okay?
Yeah, we are here since this afternoon.
Okay, but you have to stay there, okay, Dad?
Okay.
Okay, you just relax.
Yeah, okay.
Okay, how's Lucky? How's Lucky?
Lucky.
Yeah, where's Lucky?
You are lucky.
Yeah.
Lucky is upstairs.
Okay, who's that right there on the floor?
Okay.
That's Lucky.
This is the brother of Lucky.
Oh, it's the brother of Lucky. Okay, so I will stop that there. And I'll come back to Zoom here. And I think I've lost you all on Zoom. Where did you guys go? Hang on, Zoom. I am lost on Zoom here. If I can get assistance to exit Zoom. Oh, here it is, sir. Am I? Yeah, I am.
There we go.
Okay, so anyways, that is just an example of how I was using remote care back then. Some tools right now that people might want to know about is I showed the camera there. Okay, this sensor, this one that actually converts someone into a stick figure, so you don't see my dad like that. These devices, these Alexas, Google Home, high return in my opinion for 40, 50 bucks, depending. Amazon's having Prime Day soon as well, in a few days. So those are the times I tell caregivers, save 50%. Okay. I could remotely play music for my dad from a distance. Okay. Or my mom currently right now. Okay. I could have family photos that I can control from a distance. So those are the things that I just wanted you guys to see. I will be age well. I'm working with a team called WeTrack and Silverts. And we're going to be creating tracking insoles that go into shoes, okay, that can weigh yourself, things like that from a distance. So those are some of the things that you could be doing, okay? Just, I'm dumping everything to you guys here, okay? We have all these tracking devices that you can have. But there are reasons why you don't go this route as well, okay? There's pros and cons, but it depends on who you are. And that's kind of the work we did with Michael, the great research he's done. So anyways, that's what I'd like to share for now. And I will pass it over to Michael to discuss the work that was done around all of this. Okay.
Thank you, Ron. That was great. You gave such a great perspective on some specific technologies and how they're used and some stories. So I really appreciate you doing that. I'm going to pull up my slides if I can find them. Give me one moment, sorry. Okay, so hopefully everyone can see my slides. So I'm going to, oh, starting at the end for some reason. Okay, here we are. So I'm going to give kind of an additional perspective to remote monitoring technology. So Ron, I think, gave lots of great examples and how you can use it, role of caregivers. In a way, our project overall, and for this specific one, is really trying to think through some system level policy challenges and ways to think about integrating things like remote monitoring technologies at a system level. So that's the perspective we came at with this. So I'm going to give you just a bit of a sense of our timeline and where it intersects with some other work that we've done, along with a very quick snapshot of our process and inputs with more focus on our key findings from the citizen panels and the dialogue that we ran. And I'm going to end with kind of where we are now with our last phase of our Age-Well project around this effort or thinking around an integrated health innovation system, in which many ways this remote monitoring project led us towards. So in terms of our timeline, this started back in October 2022, from May to October 2022, engaged in our planning process with our steering committee. We can, in addition to that, a separate process that we worked with the BC government on, we convened a series of 4 what we called horizon scanning panels to identify and refine and prioritize innovations in health system governance, financial and delivery arrangements that could be considered for piloting and scaling up in provincial and territorial health systems. For the remote monitoring piece in November, we convened 4 virtual citizen panels with 35 citizens, with one of those being in French. That was then followed by a national virtual stakeholder dialogue with 19 system leaders. In April of this year, we wrapped up our last horizon scanning panel, which led us to this bigger picture thinking about integrated health innovation systems. And then from that project, we're now planning in February our last series of 4 citizen panels about innovation systems, which is going to be followed by a national dialogue in March. So that's our overall project trajectory. If you're interested in this project about remote monitoring technologies, our products are always available open access online on the McMaster Health Forums website. So the link is here. I can put it into the chat when I'm done as well, so you have it handy. And just because I'm going to cover kind of the highlights of this, and there's much more really detailed information in the documents that we have available that if you're interested, you could have a read. So I thought Ron's overview of technologies was fantastic. I just have a few figures from the brief that we wrote to inform our deliberative processes around remote monitoring technologies. So thinking about who are the potential users, could be healthy older adults to maintain their active lifestyle, older adults with 1 or more chronic conditions where the technology could help monitor specific indicators that could be helpful, for example, to a primary care provider, a caregiver, and whoever. Frail older adults where there's much more complex information that might need to be tracked and identified and help people stay as independent as possible. Ron talked a lot about older adults with dementia, and then also the caregivers and their role in this. They can be used to monitor things like health and wellness in one's home environment, which means that they can stay in that home environment for longer periods of time. Could be more non-invasive and engage patients in it, or it could be non-invasive and very much automated, which requires little little effort from the patient or their caregiver. I won't go through the examples of remote monitoring. I think that Ron covered all these, anything from sensors to blood pressure monitors, online portals, and they could be used across all sectors in our health system. So we usually think of our sectors as home and community care, primary care, hospitals and specialist care, rehab, long-term care, and public health. And ideally, they could be integrated across all of those to help coordinate care and help people stay at home as long as possible. They could monitor many different types of things like heart rate or breathing, body temperature, oxygen saturation or blood pressure, blood glucose, to name a few. And they can also monitor parts of someone's home. So there's many examples here, whether it's detecting abnormal behaviors to ensure safety, speech patterns to identify any emerging health issues that could be happening, wandering behaviors, which Ron pointed to in his video, among many others. So that's kind of what we're thinking for remote monitoring technologies, to ground you in what we mean by that. So when we thought of this in terms of what are the system level challenges that we have to face around using remote monitoring technologies effectively and to help people stay at their homes and live independently, we identified a number of things through our interviews with key informants, and then as we looked at the data and the evidence. One is it's hard to identify those who could benefit from different types of remote monitoring technologies. So there are so many technologies out there. Sometimes people have given us the sense that it's very hard to figure out whether and how they should be using and what they should be using. There's also a lot of areas of uncertainty regarding remote monitoring technologies. And it's hard to reconcile some of the uncertainty with what should be used. Are there limits for what should be remotely monitored? The privacy concerns that Ron also pointed to, and then combine that with a number of different challenges at the system level where existing programs for remote monitoring technologies, or just in general, the use of remote monitoring technologies, don't necessarily leverage our existing governance, financial, and delivery arrangements. So we don't have an overarching regulatory framework for remote monitoring technologies. It's not a core part of the health system yet. There's challenges in scaling and spreading the use of these technologies when there's so many, and primary care physicians' offices aren't necessarily set up to routinely use them. And it's hard for them to take on yet another role in the types of things that they do, which then speaks to also in a siloed budgeting and challenges in how people are paid, not to mention the interoperability of where the data goes, who tracks it, and where does it go into your health records. And then a lot of what we heard also is that programs aren't currently complemented with behavioral implementation strategies to help ensure that technologies get to the people who need them. So more of an implementation consideration. And so here's some things that we also heard from citizens once we put this in front of them. And I say 10 challenges here, but I actually combined a few this morning and I forgot to change the number in the header. So it should say 8 challenges. My apologies for that. And one of it was lack of public awareness about remote monitoring technologies, but also I think people told us during the panels that we convened that, they know these things are out there, but they're not really sure about how they can help support them as they age in place, or help their parents or loved ones or others. So there's a kind of a disjointed sense between what's out there and how it can actually be used in their life. Also the idea of remotely monitoring people could raise concerns and fears. Some noted, this notion of being under surveillance and privacy concerns and protection and ownership of data more generally. These are not small concerns, and they're things that we continue to grapple with things like electronic health records and access to them. There was also some talk around the costs associated with remote monitoring and associated technologies, and that it could reinforce this notion of a 2-tiered system of care, that people who have an ability to pay are going to get access to newer and better forms of care, and that's going to reinforce a 2-tiered system. So how do we help advance this in a way that adheres to our sense of universality within the health system and address those equity concerns? And whether there's a threshold for where remote monitoring technologies are no longer cost effective. When does it become a huge burden on a healthcare provider that means they can't also be doing other things? So I think we have to find the right balance. Which ones are publicly funded and when and for whom was another concern. Some concern that technologies could replace human contacts. A lot of emphasis on using them strategically alongside human contacts to more generally optimize care, and also to ensure the validity and reliability of the technologies being used, and that those attitudinal barriers can make it harder to innovate. So this unwillingness generally in our health system sometimes to step outside of the box and do something new. So in addition to the challenges, we put in front of both citizens and our system leaders three elements of an approach that could be used to address some of these challenges to inform those deliberations. The first was around supporting people and their caregivers and families to use and adopt remote monitoring technology. So in other words, how can we help people identify what they could benefit from and to use them in meaningful ways? So ways working with primary care or other parts of the sector to proactively identify people who could benefit from it. How can we financially support people to use and ensure the maintenance of the technologies? And to sometimes just, people already have these technologies on a phone or something else in their house. How do we then just hook them up to be able to do that? Sometimes it's not the technology itself, it's actually getting things hooked up and usable for their specific context and life and needs. And that's part of that implementation strategies piece at the bottom as well. The second one was around enabling organizations and providers to use and adopt remote monitoring and associated technology. So it's not just on the patient, client, caregiver side, but also helping providers do this. And a lot of this was the need to do this was framed around co-designing programs and services together to make sure those technologies are usable from both sides. And adopting more organizational targeted implementation strategies and provider targeted strategies. The last piece was around adopting a rapid learning system to support the development, implementation, and evaluation of these technologies. And by that, I mean this ongoing cycle of identifying where challenges are, how remote monitoring technologies or others could help address those challenges, build the business case around it, design the innovation, implement the plan, evaluate, and then continue to adjust and disseminate results. So instead of thinking, oh, we have a solution and we're going to put it in and just assume it's going to work, instead this is, we've got something that sounds really promising and we're going to give it a try, but we know we're not going to get it right the first time, and just be very clear about that commitment that nothing's going to be perfect when we first start it, but we're going to adjust as we go and try and do this the best we can, and that's going to put us ahead of the curve in terms of our thinking and ability to integrate innovations in our system. So when we put this in front of citizens, what we heard was that they thought the sequencing of those elements should actually be revised. So they thought, grounded in a rapid learning model to address those system level challenges, make sure that users are guiding the development, evaluation, implementation, support the implementation of robust pilot projects across many different groups of people with an emphasis on rural and remote and vulnerable communities and in real world contexts. There were many people who pointed to the fact that, it's great some of these technologies work well in a lab or an academic setting, but we need to know if they work in the real world and to build evidence from that so that we can build a business case for their system-wide scale and spread. And then also this notion of a network of regional hubs that could support collaboration. On the organizational side, they were very supportive of this co-design idea, some concern about it potentially slowing down innovation processes. I think there's ways to work through that. And then supporting people. Really, many people emphasize the need to access remote monitoring technologies based on needs and not the ability to pay. That came out very strongly across all the panels. And also having people be proactively engaged in care planning conversations to be able to match that technology to the needs and context of their unique situation, as well as need for that onboarding and additional training, and taking an empowerment approach about how this can help them and really engage them in their own care. When we talked to system leaders about this, we also put the findings from the panels in front of them in their briefs. So they heard what the citizen panel said, and they, throughout the deliberations, pointed to the need to using this to address longstanding challenges facing health systems and as a way to modernize our circle of care. And speaking about this one participant said older adults often cover up that they're suffering, and providers are often making decisions without reliable information, and this technology can be really a game changer for that. The key priorities that they underscored here were using it to be considered as a core health system function, thinking about it differently and reframing to get clients and families excited about using it, conducting person-centered empowerment-based assessments, and you're really framing it as a fun and engaging lifestyle technology perspective, and also using it to proactively drive those modernized approaches of care and teams and pathways. And really, they were also keen on the rapid learning and improvement cycles. Some additional priorities from system leaders, kind of speaking to the specific AgeWell link here, really want to examine how the mission and priorities of AgeWell linked up with some of the things that we're talking about. And that's what we're linking up with our final phase of the project, trying to create some space to engage stakeholders to work towards a unified agenda, which is what I'm really hoping comes out of this innovation system work, using things like technology accelerators and incubators to kind of pair that supply side with the demand of what's needed in systems, and empowering the public and providers to drive this narrative and continually and update that evidence base, all alongside using an equity lens in this process. A few additional key insights, and I'll turn to some questions for us. 4 factors that we found that were related to influencing remote monitoring success were: 1, the intervention design, so co-designing with the target population, making it easy and simple, using accurate measurements, some customizability, and focusing on self-management. Also having it be interpersonal, identification of patients with high risk of admission, motivation to use it, and routine data entry and frequent follow-ups. Also interpersonal, so two-way communication, self-management support, using data to personalize care, and then collaboration across teams. And then at the organizational level, important to have central monitoring unit or a dedicated personnel or somehow integrated into existing workflows and incentives. So these are kind of big system level things that need to be in place for it to be successful. We also saw from some of the literature we looked at that 3 levers as being influential for scaling and support and adoption and scaling of remote monitoring. So the need for contextual research to understand the catchment area and the infrastructure is needed, targeting a combination of local diseases to increase reach and accessibility, and then adopting that user and patient-centered design. And then I think I have, so I have 2 more slides and then I will wrap up. So for some key informant feedback when we did these horizon scanning panels, I found it really informative to talk to a number of people really engaged in this work. And they said that, the uptake has been great for some conditions like COP and chronic heart failure, but slower and more challenging in almost everywhere else. There's a lot of scalability challenges in primary care, where chronic care is typically managed, as it's not set up for primary care clinicians to do this monitoring. It's just not part of their core function in their job. And alongside that, there's this challenging with procurement of technologies at a system level. Who pays for this, and how should primary care physicians be paid differently? And the lack of availability of interoperable electronic health record backbone for all of these to hook into and coordinate with. It also needs to be, we heard that needs to be paired with personalized assessments that identify the role that an RMT can play in achieving goals, determining the right technologies that are compatible with the systems that are available, and providing that support for the hookup. So this is not just an individual, but allowing this to operate at a system level. And this is our preliminary thinking about this innovation system. So I won't go through this in detail, but just give you a sense that in thinking about innovation and how do we support scale and spread of these types of innovations, we've heard very strongly that there's this, on the demand side, what we need is for policymakers and decision makers to identify the purpose for the innovation, whether is it to lessen the capital intensity of healthcare, build a business case about it, but also provide this innovation backbone that lets suppliers on the bottom part of this figure to plug into the system and start testing. And so the need to be able to test, identify what's working, what's not, adjust, and then the system leaders need to be able to figure out which ones are we going to scale at a system level, and whether it's system being a region or a province or whatever it may be. So this is just some preliminary thinking, and I can come back to this if you want, but I will end there because I feel like I've probably talked for a while, and it's be good to hear some questions. So thanks, everyone. So I can stop sharing, but I can come back to it if it's needed.
Thanks, Michael and Ron, for handling this technology so well in terms of our Zoom technology. But yeah, and thanks for that overview. And it was really great, Ron, to have you contextualize with your experiences. And I will speak for myself in terms of I really appreciate you sharing your personal footage with us. I know that must be difficult given that your dad's passing. However, it does help us understand some of the complexities that Michael then dove into on the other side, right? With what we really need to be thinking about. And I think Liz, one of the participants asking, some questions in the chat about how do we implement, how do we pay for some of these technologies, right? And Ron, using Skype way back when, right, for that. So all of that to say, I mean, so many important points raised today in terms of the conversation, and I'd like to open it up for questions. We will again break for the reflecting together at 1 o'clock, but we have some time, and thanks, Mike, for giving us some time, and Ron as well. So I'll try to hold the awkward pause here.
No, well, while some people are going to put something in the chat, which we're hoping for, I will address Liz's comment in a little more detail. Because Liz was asking about funding, right? And again, Michael talked about it. I call it my ROIs, So my goal, okay, that I keep pushing that I would like to see is that how could we have, let's say, the healthcare community prescribe technology, okay? So there's prescribing pharmacological solutions, right? We got the pharma industry there. There's a part of me that says, well, why can't my dad's doctor, if I say, hey, my dad is at risk of going missing, instead of giving him a pharmacological solution to knock him out and not my first choice, said, we want him out there. We'll prescribe a GPS technology. One company, I mentioned them earlier, WeTrack, full disclosure, I do advise with them. WeTrack based out of Pickering. I challenged them, and they actually got their technology of tracking solution as a class 2 or class 1 medical device. Okay, so that is technology that a doctor can say, we're going to prescribe you this, okay, technology, your insurance could cover it. Are we there yet? No, but this is why the work that Michael has done is quite important to show. And just the last comment on that, here's an example in the West Coast, some people would have heard that there was social prescribing. So doctors prescribing park passes to someone, okay? Here's your park pass. It doesn't have to be all pharmacological, okay? But however they got that program going, that's what I'd love to see for technology. So Liz, great question. We just need to come up with more creative solutions and move the work forward.
Yeah, as Michael well knows, sometimes the system has to play catch up, right? But it helps to know what they should be catching up on in terms of priorities. And so the citizen engagement part, Michael, so critical, right? And showcased here today with you and Ron, of course. Rebecca has raised her Zoom hand. Doesn't she have great Zoom etiquette? Yeah, so Rebecca, kindly unmute yourself, which she just has done, and go for it.
Thanks so much. Thank you both for a really excellent presentation. And Ron, you've heard me say before, because for those of you that don't know, I've had the pleasure of partnering with Ron in a number of initiatives. But whenever we meet patient partners in another conversation, we're always learning new things or different aspects of their experience. So thank you for sharing your experience with all of us in this conversation. And I learned some more things today, so that was a pleasure for me. One of the things that I wonder about, and I appreciate your comments that you just made, Ron, about, where do we go from here, and thinking about these non-pharmacological approaches, and thinking about, and so it sort of ties with what I was going to ask maybe the two of you. And so maybe I'll direct it to Mike, but maybe Ron, I'm happy to hear from you as well. But I'm wondering from the panels and the deliberations, because these are these big system issues. So I wonder if there were any quick wins. Like, where do we start? How do we start moving forward on some of these agenda items? So I'll just leave it broadly, and happy to hear your thoughts.
Yeah, I mean, that's the question of the day, right? So, and it's a good one and a hard one to answer definitively. So when we did these horizon scanning panels, for example, we had a number of provincial decision makers in that panel, and we were trying to identify things that they could try now. And they were really hoping for, we could give them, here's 3 things that are ready to go. It was not that easy to do, unfortunately. And so remote monitoring was one of them, and there were some core examples in there. I'd have to go back to some of the specifics, but I think they were excited about the potential of testing out remote monitoring along with what Len in the chat pointed to about using AI to integrate some of the data, integrate and analyze some of the data. So things like early warning systems that can help use the remote monitoring data and to provide an alert or something to a caregiver or a care provider to be able to say something isn't quite right here. We need to now pay attention, like, alert to someone needing an intervention or support. And so I think there's some opportunity to start trying out things like that, especially as AI becomes more refined and accurate in its ability to do this. But for me, what it comes back to is that last figure I had, which was kind of pointing to the decision makers really having to point to clearly what is the system challenge or challenges that they want to address, and then building the business case. And then it's the suppliers that come in and are able to say, look, we have stuff that is almost ready to go for this, and we can adapt, and then we can try and evaluate if you give us a chance to actually roll this out in a meaningful pilot. So I think that's for me where the disjuncture happens, is that there isn't enough opportunity for helping some of the innovators and businesses to then connect into the system in a meaningful way, so that 1, we can strengthen the system, but then 2, we can also strengthen our innovation system, which many have pointed to as kind of being small and could be really improved if given this type of opportunity. So it's a bit of a non-answer, but also I think some bigger system implications there, Rebecca.
Michael, you actually, it's a great answer. That's actually what I was going to say. It's coming from the innovation side. Sometimes we always wait from the policy, the healthcare. For me, the caregiver, the families, we don't have time to wait for that, right? If we're in the fire right now, I will go to Best Buy. I will look at Home Depot. What are the things I could grab right now and figure out? But that was back then. Now we have all the innovators, across Canada especially, coming up with all their solutions, but they can't get in. Okay, for some reason, they're not getting enough pilot tests coming in. AgeWell is helping with that. Research is allowing to have that, but working with some of these organizations. Okay, so I'm going to pick again the examples I gave with dementia, Alzheimer's societies. Okay, so the Alzheimer's Society saying, hey, get a pilot project, get the research person together. We have 3 innovations ready to go. Okay, get that to your community. Home care providers. Okay, home care services, the aging in place. So it is that who gets to the table is the quick wins for me, but the innovators are there waiting. Okay, and some of them, as Michael said, they're coming up with these solutions, developing them, but some of them are ready. Okay, that have been already ready. They just can't get into this community because no one's getting them to the table, and they have to spend the money on marketing, getting it to Best Buy, whatever. So, Michael, that was kind of my answer as well, is that innovation side. They're ready.
Yeah, thanks, Ron. And I think we have everybody can take a look at the chat. And Vanessa has made a comment, I think, Ron, some of the coordination you demonstrated, right, and listed. And I can it's one thing to list it linear. I can only imagine what's happening behind the scenes, right, in terms of that coordination. So I don't know if you want to comment on.
So Michael used a word which I don't know how many people know this word, interoperability. Okay, so that is a big, long word. I don't even know how many syllables, maybe 10. Okay, but interoperability, to me, that maybe doesn't know that word, it's saying, oh, I have to bring something to the doctor. Okay, it's on this device, it's on this, it's on as well this, and I got some paper notes. Okay, so all that coordinating gets messy. Okay, I'm pretty good at putting it together. At the end of the day, here, doc, here is a 1-page printout of this update. Okay. Can we do that better? Can we do that faster? Do I need to spend 5 minutes with my dad's doctor at the appointment, showing him all the data that we have, versus remotely now, what's happening, it's shifting where primary care can get some of that data possibly ahead of time. So it's, I don't even have to go to the appointment, maybe. It's going to flag saying your dad doesn't have to come. We saw his weight, we saw these health details. So as we were saying, this is not directly the caregiver and my dad. This could be my dad, directly with his healthcare primary care team, let's say. So when you're talking about coordinating care between all these providers, yes, it's messy, Vanessa. It's going to be messy for a while. I'm going to let you know it's not going to go away anytime soon. But we can get better. Okay. Caregivers on our side, we can make it easier. You know, we can make our coordination easier with all these tools as well. So I won't tell you how to do that yet. Too long for that, but that's where technology comes in.
Yeah, and yeah, not surprisingly, you know, we have suggestions in the chat as well from Len, right? Trying to think about different ways that we can, yeah, those opportunities for innovation. And I know it's as Ron said, it's hard to get in there. I think in terms of the way our system is set up.
Yeah.
Go ahead,
Brenda. But I got to mention, like, I'm respecting what Len's doing here. Like, to find a Len, to find a Ron, there's not that many as well, right? Like, how many Len Collins? Len, your name's out here, so I have to call you out there. Okay,
yeah,
we'll know this information. Okay, that also has to be moved up as well. As Michael's saying, you know, we have to find ways so that people can get educated quicker. Can, like, again, I use the plumbing example. All of you can promote a dishwasher, a washing machine, a sprinkler system by now, right? You understand how it works. We need to get the general population comfortable to have these conversations, that it's not new, but it'll still take some time. But yeah, we need more Lens in the world, say.
and Liz, Michael has, you know, noted, I know the Health Forum works with many countries and globally as well, and she's just made a comment about what, you know, what are other countries doing. Canada is quite unique in terms of how large it is, right? When we look at some of our Scandinavian counterparts, yeah, the size of Canada is a bit more of a challenge. But I don't know if you have any comments about this, the approaches used by other countries.
I'd be curious from Michael's side, as that academic who gets to go to all these conferences.
Yeah, I don't go to all that many conferences, but yeah, in terms of other countries, I'll come back to the horizon scanning panel, because one of the things we did was try and do a big scan of kind of new and different innovations that were coming up that were kind of being tried in small numbers of other countries, or essentially that we weren't doing here. So innovative to us, not always necessarily innovative to others. And so that was kind of the initial thinking behind some of those panels. I'm putting a link to that horizon scanning piece in there. And that led us to things like, I'm just refreshing my memory of these kinds of things, like the types of remote monitoring programs that are used in other countries, but are enabled by, and I'll come back to that word, interoperability. So you have the Kaiser Permanentes of the world, you know, in the US, who essentially have an interoperable system with, you know, health records connected across an entire system for a large population. We do not have that here. So the challenge for us is that we need to play so much catch up on the system side to even get to the point of being able to use some of those innovations. So part of the reason why we see some remote monitoring companies going to the US after they started in Canada is because they have a population base that they can then scale up and spread and use because of the system backbone that's in place that lets them test rapidly, but then also adjust and scale up. And we just don't have that level of interoperability here, and it's challenging for making that work. And so there are some examples in that horizon scanning piece. I'd actually have to go and refresh myself for some of this very specific examples for you, but we do, you know, this type of work and others routinely do things like jurisdictional scanning to find out not only what the evidence is saying, but what also some experiences are with some of the jurisdictions.
Thank you, Michael. And with that, I want to thank both you and Ron for sharing your expertise with our group. And I think as these conversations go, we sometimes just feel like we're just getting started. But luckily, we have the reflecting together part, which can extend our conversation and provide a bit more depth. And so I will hand the proverbial mic over to our older adult partner, Michael Kirk, who will talk to us about the reflecting together piece. So thanks again, Michael Wilson and Ron Beleno, and over to Michael Kirk now.
Wow, what a lot to unpack. As an end user for this technology and these advances, I'm really excited, and I'm terrified too, that we won't get quite all of them in my lifetime. So the reflections part of the session is more or less a roundtable where not only we get to share those things that we're thinking about, but how we're feeling about them. And in embracing any kind of new or advancing technology or way of doing things, how we feel is sometimes as important or maybe more important than the actual how we do it. By way of some of the impressions that I got, Ron, I was so impressed with that short video you showed of your dad, because to me, it hits the epitome of what our target is. It's weird to keep we older adults in our own homes where we are anchored. Your dad was anchored because you were there to be able to talk to him, and he had Lucky there as a physical anchor. So important. So for the next while, I encourage anybody to jump in at any time. I will try and watch for hands raising. If I don't catch your hand up, please just step in, share the mic with everybody. Ron, go ahead.
So I'm going to raise my hand while people are warming up to this. So Michael, thank you for that comment about the video. Oh, there's two Michaels now, I got to say. So Michael Kirk. You actually touched upon the emotional piece, which is huge. I don't think people realize the importance of understanding the emotion attached to all these solutions or why we're doing it. Okay, and I've always challenged innovators, even researchers, okay, that are doing this work, the so what question. So what? What will this do to me, the caregiver, to my dad? What are the emotions that can come out of this? Okay, and that's how I work backwards, because Michael, you're key. For me, if you remember some of my slides, I threw in emotions was something I'm solving for. The return on the emotion. So a GPS device, a sensor, okay? What I was worried about was the fear. So on a scale of 1 to 10, my dad going missing would be an 8, 9, 10, okay? Having a sensor, having a GPS to find him if he's out there, reduces that fear level and gives me confidence in my emotions, okay? Gives my dad joy to be out there. So Michael, you hit on a key piece that I think many people forget about. And thank you for that there. And yeah, Lucky is a good example of calming his emotions down as well, right? So thank you.
Yeah, and that's an old concept around that comfort index with anything we do. The higher our comfort index, the more we're liable to adapt to it. So it's building that first of all.